As far as we know, the basic molecule for oxygen transportation within our body is hemoglobin. Hemoglobin is a compound consisting of the iron portion, heme, and the protein chains, normally 4 protein chains, 2 alpha, 2 beta, that is globin. So, in case of sickle cell anemia, as it is called hemoglobinopathy, it has a mutation, missense point mutation for the genes coding for the beta globin chain. Glutamic acid is replaced by valine at 6th position. This is normal hemoglobin structure. This picture is visible from the last bench, for the last row. Say yes or no? So, this is a normal hemoglobin structure, 2 alpha chain, 2 beta chain and heme units attached to the iron atom. This is normal hemoglobin. This variant is called hemoglobin A. That is most predominant hemoglobin in our adult body. Now, A1, hemoglobin A1, the 97% adult hemoglobin consists of 2 alpha and 2 beta chains. Hemoglobin A2 consists of 2 alpha and 2 delta chains. And hemoglobin F, the fetal portion, the fetal hemoglobin carried the in utero oxygenation and deoxygenation that is present 70 to 90% at birth, 25% at 1 month. Then it gradually replaced by hemoglobin A1. A1 variety that is most predominant. So, sickle cell anemia is an autosomal recessive. Okay. Just for the MCQ purpose, which disease is the autosomal dominant one, which disease is the autosomal recessive one, you get very frequently this type of questions in your PG entrance examination. So, for reminding you that any disease that occurs with clinical manifestation of structural deformity, like chondroplasia, like short limbs, like any deformity or any congenital disease that comes with structural deformity, most commonly autosomal dominant one. And the diseases, congenital defects, which are accompanied with inborn error of metabolism due to deficiency or mutation of any enzyme or anything, any enzyme, that is a most commonly autosomal recessive one. So, sickle cell anemia is an autosomal recessive genetic disease that results from the substitution of valine from glutamic acid in position 6 of the beta globin at chromosome 11, leading to production of defective form of hemoglobin S. So, this far we have encountered 4 to 5 types of hemoglobin. The most common one, hemoglobin A1, adult most predominant form of hemoglobin. Hemoglobin A2, another hemoglobin variant. Hemoglobin F, the fetal hemoglobin. And now the hemoglobin S, the sickle cell hemoglobin. So, hemoglobin S or sickle cell hemoglobin is a structurally defective hemoglobin, so that the cell membrane of the RBCs, this picture can be seen from the last row. This picture, let me check. Okay. Letters are not vivid, but you can see the pictures. In the center of this picture, we can see the RBC, the normal biconcave disc-shaped RBC, because of the mutation. So in this picture, this portion demonstrates what the sickle hemoglobin or sickled RBC looks like. This is normal oxygenated biconcave disc-shaped hemoglobin. Those who attended the DOAP session with the teachers showed the students what are the various shapes of RBC, how RBC look like under the microscope. Is it? You all see RBCs under the microscope. So normal RBC, in normal instances, it forms a shape of disc or biconcave shape. But in case of presence of defective hemoglobin, hemoglobin S, the RBC first they form a irreversibly sickled shape. So distortion of the membrane and the RBC from biconcave shape or disc shape, it attains a shape of a sickle. But this change is transient. Primarily or in the early time, these changes is transient. So before the oxygenation improves, the reversibly sickled cell may go back to the normal biconcave disc shape. So as long it is reversibly sickled, and if the deoxygenation continues in its severity, then the cells become irreversibly sickled due to hemoglobin S polymerization. So hemoglobin A is very different from hemoglobin S in terms of its increased adhesiveness, increased aggrability, increased stickiness. So the irreversibly sickle cell, they forms HBS polymer which actually aggregates themselves and make a clot to the vasculature, causing the vascular symptoms, cell adhesion, more stickiness, microvascular occlusion by the sickle cells, or either the cells are being destroyed by the spleen, by the splenic sinusoids. Okay, so sickle cell anemia, the main defect is with hemoglobin S. This is a structurally defected hemoglobin. So hemoglobin S, the chief clinical manifestation of sickle cell hemoglobin, so broadly classified into two categories. You remember just these two categories, then you need not to study all the clinical manifestation in detail, as you can enumerate the clinical manifestations of these episodes from your own. What are these two broad categories? Number one, hemolysis, the destruction of RBC. So destruction of RBC if occurs, what kind of symptoms patient will have or patient will encounter? Like fatigability, what? Malignancy. Anemia, very good. Anemia, the clinical manifestation is pallor, fatigue, high pulse, tachycardia, okay? Then another clinical manifestation of hemolysis, increased chance of infection, increased bilirubin, very good, increase of indirect bilirubin due to destruction of the hemoglobin portion, hemoglobin to biliverdin, then bilirubin. So one clinical manifestation, one category of clinical manifestation, it has been shunted due to chronic hemolysis, and another severe most clinical manifestation are attributed due to the cause of vascular occlusion. Okay, I earlier said hemoglobin S, this is structurally different hemoglobin. It has increased tendency to stick and make adhesions like with other RBCs. So all together they have a capacity to occlude a vessel, to occlude the vascular flow, to jeopardize the oxygenation status and nutrient status of the cell, and the cell suffers from hypoxia. And we get symptoms and clinical signs of patient due to the effect of vascular occlusion. Okay, am I clear to everybody? First cause is hemolysis, and next big cause is vascular occlusion, hypoxia, the cell injury. We started it in very early days. So vicious cycle of hypoxia, obstruction and sickling goes on if the oxygenation status of the patient gradually deteriorates by environmental factor or by some other factors that I will explain you in later. So changes in properties of sickle cell RBC, I earlier said deoxygenation leads to hydrophobic interaction of adjacent HBS molecule. HBS molecule is like a great friend, a crowd puller. ওর ঘরে পার্টি হলে সবাই চলে আসে, তারপরে ঘরের দরজা বন্ধ হয়ে যায়, সবাই বেরোতে পারে না একসাথে। This leads to hydrophobic polymerization of red cell membrane. Hydrophobic polymerization. The red cell cytosols become viscous gel as hemoglobin aggregates form and become needle. The polymers, they took shape of needle. With continued deoxygenation, distortion of RBC into sickle form cells, rapid hemolysis, decreased elasticity of the cell wall of the RBC. So the lifespan of the RBC, it gradually decreased down from 120 days to very less. So hemolysis episodes occur. Decreased lifespan of 10 to 20 days. Just imagine 1/10 of normal life, and clogging of RBC in microcirculation that leads to various vaso-occlusive crises like stroke, like retinopathy, like acute chest syndrome, acute coronary syndrome, like gangrene of the toes, dactylitis, that I will show you later. Autosplenectomy, very good, autosplenectomy. Major pathologic manifestation, chronic hemolysis, microvascular occlusion and tissue damage subsequent due to continued hypoxia. Hemoglobin S and other forms of hemoglobin cells, very important. Hemoglobin C, another variant. We have encountered hemoglobin A1, hemoglobin A2, hemoglobin S, hemoglobin S. Now we can see that hemoglobin C is another variant of hemoglobin. So this is also hemoglobinopathy, and if hemoglobin C, it actually increases the adhesiveness of the sickle cell or hemoglobin S. So hemoglobin C, presence of hemoglobin C is an aggravating factor of sickle cell anemia or sickling episodes. Hemoglobin C is a co-enemy for the hemoglobin S patients. And in the contrast, hemoglobin F, that has extremely tremendous capacity of carrying oxygen in utero, it has a friendful effect, it has a beneficiary effect for the hemoglobin S patient or sickle cells patient. Okay, so hemoglobin C, that increases the effect of hemoglobin S or sickle cell anemia, and hemoglobin F, this is our kind of friends for hemoglobin S patient. So as we seen earlier that hemoglobin F is predominant form of hemoglobin up to 6 months of age, neonatal age. So the episodes or the clinical manifestation or the symptoms or the complications of sickle cell anemia, they usually don't manifest up to 6 months. As because of that, hemoglobin F, the HbF, that is friends for the, this is an autosomal recessive disease. So clinical manifestation, I earlierly elaborated, due to vaso-occlusive crisis, hematological crisis, aplastic crisis, sequestration crisis, autosplenectomy. The spleen is sequestrated by its own. Infectious crisis due to decrease in the total cell count, decrease in neutrophil count, destruction or increased RBC destruction means increased bilirubin, and indirect form. Okay, bone pain due to avascular necrosis, liver and spleen, splenectomy, And hematological crisis, acute splenic sequestration, pooling of blood in the engorged spleen, aplastic crisis seen in patient of parvovirus B19 infection, aplastic anemia, destruction of the bone marrow precursors due to triggered by infection, anemia, pigmented gallstone due to destruction of RBC, the indirect bilirubin portion increases and bile stones or pigmented gallstones form. Jaundice, indirect form of jaundice, delayed growth due to decreased circulation to the bones and delayed growth of the child. Auto-infarcted spleen, gross specimen. Auto-infarcted spleen. Splenic pathology, this is histopathological picture, dilatation of sinusoids, inflammation, hemorrhage within the splenic pulp. Histopathological picture. The left hand side of the picture is the scanner view or the low power view with higher, broader field of vision, and the right hand side that is high power. Gallbladder, pigmented stone, black color stone, pigmented stone. The same questions may be asked from your surgery professor. Normal spleen and splenomegaly due to peripheral splenic pooling of blood. Infectious crisis, I told you earlier, due to absolute neutropenia. The patient are more prone to catch infections due to decreased count of neutrophil. Various infective agents like Haemophilus influenzae, PIM, Pneumococcus influenzae and Meningococcus. Just remember for MCQ purpose, if a patient don't have spleen or if a patient might lose his or her spleen for any crisis like thalassemia, sickle cell anemia or any pathology, the patient is being instructed to have vaccine against 3 organisms. The mnemonic is PIM, P-I-M, not PM, P-I-M. Pneumococcus, P for pneumococcus, I for influenza, and M for meningococcus. So, pneumococcus, influenza, and meningococcus, these 3 are most dreadful organisms for a patient who don't have spleen. He can usually get infections from the organisms. CVS, acute chest syndrome, acute coronary syndrome, pulmonary acute chest syndrome, acute myocardial infarction for CVS, CNS, strokes, transient ischemic attack, TIA. You got cases in your, you will get case in your clinical class postings, TIA. Cerebral hemorrhage, hepatobiliary system, gallstone, recurrent abdominal pain, urinary system, hematuria, due to papillary necrosis of the kidney. প্রত্যেকটা মাথা থেকে পা অবধি সিস্টেম, just close your eyes and you can easily enumerate the symptoms or complications. Orthopedic hand foot syndrome, avascular necrosis of the hip and osteomyelitis. Fish mouth appearance of the bone. Proliferative retinopathy, fundal examination. Proliferative retinopathy due to microvascular occlusion in retina. Avascular necrosis of the bone. Most commonly occurs in long bones. Head of long bones has more prone to vascular ischemia because the vasculature of the neck are climbing up and then draining downwards. So avascular necrosis of the hip, humeral head, avascular necrosis. ও তোদেরকে একটু দেখাই, এই যে নেক্রোস পোর্শন দেখ, এই দেখ হিউমেরাস হেড। আচ্ছা আগের ছবিগুলো দেখাই, এই যে রেটিনোপ্যাথি দেখ, ভাস্কুলার, একটু হাওয়া ধার নিচ্ছি তোদের থেকে। প্রলিফারেটিভ রেটিনোপ্যাথি, ফিশ মাউথ অ্যাপিয়ারেন্স, সব এগুলো ভাস্কুলার অক্লুশনের জন্য হচ্ছে। এটা দেখ ছবিটা, এটা স্প্লিনিক সাইনুসয়েডস, কনজেস্টেড, হিমোরেজ, হিস্টোপ্যাথোলজিক্যাল পিকচার। এটা স্প্লিন, নরমাল স্প্লিন কিন্তু হিমোরেজ হয়ে গেছে। এই যে স্প্লিনিক সাইনুসয়েডস, ভাস্কুলার প্রলিফারেশন, হিমোরেজ ইন দ্য ভেসেলস, ঠিক আছে, এগুলো ক্রনিক লিম্ফোসাইট যেগুলো স্প্লিনে সিকুয়েস্ট্রেশনের পরে হয়েছে। Okay, pediatric manifestation, most common, dactylitis, very unfortunate child. And this clinical manifestation, it occurs after 6 months. As I say, that hemoglobin F is friend for the hemoglobin S patient. So dactylitis, most common clinical manifestations of the children. Pregnancy and sickle cell disease, pregnancy induced hypertension due to narrowing of vessels, premature death of the baby may occur in sometimes. Stillborn, birth weight lower, growth retardation, infection is more severe, bladder infection, urinary tract infection, increased chance of PIH, pregnancy-induced hypertension, and preeclampsia, increased evidence of PPH, means postpartum hemorrhage. Nice. Medical complications, we will get, I can elaborate all the things, but I don't think that this class is quite suitable for taking class, giving lectures and listening to you peacefully. So much humid this place for the technical glitch. So medical complications are pain episodes, strokes, increased infections. The chart is easily visible from the last row. Last row তোরা দেখতে পাচ্ছিস কিনা দেখতে যাচ্ছি না, ফ্যানের হাওয়া খেতে যাচ্ছি। দেখি লাস্ট রো থেকে দেখা যায় কিনা তোমরা দেখতে পাচ্ছ, দেখা যাচ্ছে? ও দেখা যাচ্ছে, ভালো। আচ্ছা, পেন এপিসোড, স্ট্রোকস, বোন ড্যামেজ, আই ড্যামেজ, ডিলেড গ্রোথ, ওকে, low red blood cell count, anemia, fatigability, early gallstones, lung blockage, painful erections in men, priapism due to microvasculature occlusion for the glans penis, very painful situations for the unfortunate men. Investigations, what are the investigation you need to carry out for a patient of hemoglobin S or sickle cell anemia? Hemoglobin may be low, 6 to 8 gram per cent, reticulocytes high due to increased destruction of the RBC, increased turnover of the bone marrow, red cell precursor, peripheral smear mesh of sickle cell, features of hyposplenism, target cell, Howell-Jolly's body, target cell, Howell-Jolly bodies, few group A students or group B students saw earlier. This is all features of hemolysis. Sickle solubility test, sickling test with a, so this is nucleated, these are nucleated RBCs. Teardrop cell, sickle cell, target cell. Hemolysis is predominant in peripheral blood smear. So hemoglobin electrophoresis is the gold standard of investigation. It shows sickle cell trait and running of hemoglobin S towards the electrode, and this is sickle cell anemia or homozygous state, and this is heterozygous state. Okay, homozygous state, the hemoglobin amount is increased or the hemoglobin S content is double than that of heterozygous. So in electrophoresis, this is a homozygous state, sickle cell anemia, we can get this picture, and sickle cell trait, we can get this picture. Hemoglobin electrophoresis or protein electrophoresis, same kind of picture interpretation. You have to do it for your own or the exam purpose, very important. Electrophoresis of proteins in multiple myeloma. Okay. Treatment, oxygenation, pain management, NSAIDs, opioid, hydroxyurea, folic acid for the increased maturation of the nuclear material or nucleus, folic acid, hydration, blood transfusion, most important, antibiotics, penicillin group for treating the infections, steroids for suppressing the inflammation, bone marrow transplantation and gene therapy. Blood transfusion is the most common form of management for acute, to combat acute crisis of sickle cell anemia. Blood transfusion reduces the pain by increase the number of functioning RBC. Okay, so increasing the oxygen capacity of blood most rapidly attained by the blood transfusion. Bone marrow transplant success rate is 90 to 95%. helps in production of healthy RBC from transplanted bone marrow. Gene therapy, very expensive, not frequently done in most of the centers. Defective mutants has been replaced by the new functional competent variant of hemoglobin. Other treatment complications, surgery for the eye problem, irrigation surgery for priapism, wound care for the leg ulcer, very important to limit the infection spread and to prevent the secondary infection. Dialysis for the papillary necrosis or kidney failure patient. Cholecystectomy for pigmented gallstone patient. Hip replacement, very common for avascular necrosis of the hip patients, mostly in old age, extremities of age. How can sickle cell anemia be prevented? Genetic counseling, to premarital investigation, hemoglobin, HPLC, electrophoresis, pre-implantation genetic diagnosis before the fetus being implanted to the uterus, it can be prevented, and prenatal testing by amniocentesis and chorionic villus sampling around 16 to 18 weeks and 9 to 10 weeks. So, if the parents, they go for an abortion, medically correct abortion, they can go for it as their child or their in utero product, it has been defective. So, genetic counseling by HPLC of the both partners before marriage, important for everybody. HPLC of hemoglobin, serology, these are mandatorily done before marriage. Arranged marriage or love marriage, this must be done. Few tests. Okay, precautions, regular health checkup, preventing infection, preventing stroke, transcranial Doppler ultrasound every 3 months, fundus examination, fundoscopy every 3 months. Avoid alcohol, smoking, cold climate, high altitude exposure. All these can lead to hypoxia or decreased oxygen status, increased stress level. Vaccination for PIM, pneumonia, influenza, and meningitis. And another, last of the lot, sickle cell anemia may be the result of a genetic mutation, historical fact that happened in a malaria-prone regions like Africa thousands of years ago. So people with sickle cell trait may have been more likely to survive for the malaria epidemic, and because they survived when others did not. This is a historical fact that people with sickle cell trait, they are more powerful against malaria epidemic. So they survive through generation, having a trait for hemoglobin S, but others, the normal hemoglobin A1 carrier, they didn't survive. So this is a historical fact. And finally, thank you.
Most important word, reversible. General anesthesia. Reversible loss of all, whatever you said. So it has to be reversible. If it is irreversible, the patient won't return back. So it has to be reversible. So what all do you give? General anesthesia. What is the protocol? What are the cardinal features you all said? Kiki hobe. There has to be amnesia. Patient who doesn't want to remember whatever has gone in the perioperative period. Bhulte hobe. So amnesia or analgesia. Batha. Thakbe na. Muscles should be relaxed. The procedures can be carried out easily. Next, আর কি বললে? আর loss of consciousness. The patient will be sedated. ঠিক আছে? So these is the cardinal features of anesthesia or the general anesthesia, what we are studying. What is the protocol? What all do we give? প্রথমে কি দেওয়া হয়? There are few drugs that are given before giving the anesthesia. What are they called? Pre-anesthetic medications. So, use of drugs before administration of anesthesia to make it more pleasant and safe. That is pre-anesthetic medication. Short note aste pare. Pre-anesthetic medications. Okay. So, what are the drugs that we will be using? What are the aims? Why are we giving these medications? Before any procedure, the patient is anxious, bhoy paye sabaike. So, to relieve that anxiety and apprehension preoperatively. Next, amnesia. I told you, no one wants to remember everything that is going on in the OT. So amnesia for the pre and the post-operative events. Next, supplement the analgesic effect. General anesthetics, they have the analgesic effect, but some have the weaker analgesic effect. So the patient will be feeling pain. So we add on the analgesics to make it a strong analgesic. Decrease the secretions and the vagal stimulation. Okay? Vagal stimulation হলে কি হয়? Bradycardia. Okay? Decrease the secretions. কিসের secretions? Salivary glands and GI tract, okay, salivary gland and bronchial secretions. When the patient is anesthetized, bronchial secretions গুলো তো জমা হবে, সেগুলো patient অ্যাসপিরেট করে নিতে পারে। ওকে, আর গ্যাস্ট্রিক secretions থাকবে, সেগুলো লাংসে যেতে পারে। So that will cause pneumonitis or so we need to decrease the secretion. Anti-emetic effect. Anti-emetic means vomiting or the nausea tendency because of the analgesics. We know strong analgesics or the opioids which we give to relieve the anxiety will have the emetic effect. So we give the anti-emetic. Decrease the acidity and the volume of the gastric juice. Volume is decreased, pH is increased. Even if the patient is aspirating, the pH is so high that it will not cause chemical pneumonitis or damage because of the acidity of the gastric juice. So what all we are giving? Anti-anxiety drugs. For amnesia, we are giving the drugs. We are giving analgesics for analgesia. We are giving drugs to decrease the secretions and antiemetics, and we are giving drugs to decrease the acidity and the volume of the gastric juice. So what are the drugs that we are giving? Pre-anesthetic medications. These are the list of drugs that we give before giving the general anesthesia to the patient. So sedative or anti-anxiety drugs, opioids, anticholinergics, neuroleptics, antiemetics, proton pump inhibitors or H2 blockers. Okay? সবার বলে দিলাম কি কাজ আছে। Now the group of drugs I have told you. Sedative or the anti-anxiety drugs. What are we giving? Benzodiazepines. What will the benzodiazepines do? It will produce tranquility and smoothen the induction. Tranquility mane? It will calm down the patient. Okay, it will make the patient calm and composed so that we can induce the anesthesia smoothly. Okay, loss of the recall of the perioperative period. There is little respiratory depression or accentuation of the post-operative vomiting. It counteracts the CNS toxicity of the local anesthetics. What all benzodiazepines can we give? Diazepam, lorazepam and midazolam. These are the drugs that we generally give. Opioids, morphine or ethylene. Why are we giving this? Opioids কেন দিচ্ছি? কি effect আছে opioids এ? It will reduce the anxiety. It will produce the pre and the post-operative analgesia. Opioids, very strong analgesic effect. It will smoothen the induction and it will reduce the dose of the anesthetics that are required. Because it supplements what? It supplements the poor analgesics. Those general anesthesias that have poor analgesic effect, that means অতটা পেন রিডিউস করতে পারে না, we supplement it with the opioids. তাতে কি হবে? জেনারেল অ্যানেস্থেসিয়ার ডোজটাও কম লাগবে আর পেশেন্ট পেনও ফিল করবে। ওকে, so this is the role of opioids. And also the post operative restlessness. After recovery of the patient, একটা restless patient is restless, so that restlessness is also reduced by giving the opioids. So these are all the benefits of opioids. What are the disadvantages? It depresses the respiration and it interferes with the pupillary signs of anesthesia. When the patient recovers or patient is going into the anesthesia, we see the pupils dilate করেছে, and when he is recovering, again constriction হচ্ছে কি, that will be interfered by the opioids. So that is one disadvantage. There will be fall in the BP during anesthesia and it can precipitate asthma and tend to delay the recovery. Recovery delay করে। General anesthesia দেওয়ার পরে আমি recover করতে চাই after 1 hour, so that will be delayed. Recovery delayed হবে। Lack of amnesia, flushing and delayed gastric emptying and biliary spasm. These are all the disadvantages of opioids. Anticholinergics. Anti-secretory effect আছে আমরা দেখেছি, it will decrease the secretion of bronchial and salivary glands, as a result of which there is less chance of aspiration pneumonia. What are the drugs that are we using? Atropine, hyoscine or glycopyrrolate. These are the drugs that we generally use. It reduces the salivary and the bronchial secretion, and it has to be given before giving the anesthesia. It has to be given beforehand. Okay. It prevents the vagal bradycardia and hypotension. Prophylaxis of laryngospasm precipitated by the respiratory secretion. Hyoscine also causes amnesia and it has got anti-emetic effect. That is an add-on effect of the hyoscine. What is the effect of glycopyrrolate? It is twice as potent and it is longer acting. So we prefer glycopyrrolate. In most of the pre-anesthetic medications, glycopyrrolate is preferred because it is longer acting and it is more potent. Okay. Anti-secretory action is also more marked than atropine. Tachycardia is less. Neuroleptics. Chlorpromazine or triflupromazine, it is infrequently used. Okay, infrequently. Antiemetics. Compulsory, has to be given. What are the drugs? Metoclopramide, domperidone, ondansetron. These are the three group of drugs that we are using. Metoclopramide, it reduces the post-operative vomiting, enhancing the gastric emptying and tone of the lower esophageal sphincter. If the tone is high, then chances of reflux will be high or low. Lower esophageal sphincter এর টোন যদি বেশি থাকে তাহলে রিফ্লাক্স বেশি হবে না কম হবে? কম হবে। Lower esophageal tone যদি মেইনটেইন থাকে, when you are giving general anesthesia সবকিছু রিল্যাক্স হয়ে যাচ্ছে, lower esophagus এর যদি টোনটা লো হয়ে যায় তাহলে more chances of reflux. So if the lower esophageal tone is maintained, chances of reflux will be low. Clear? And it also reduces the chances of reflux and its aspiration. What I told you, aspiration is chance of reduced. Domperidone, it does not produce extrapyramidal side effects. Metoclopramide ki ache extrapyramidal side effect. That is a disadvantage. Domperidone ki ache extrapyramidal side effects thake na. Okay, that is an add-on advantage. Ondansetron, it is 5-HT3 blocker. We know that. Highly effective in reducing the incidence of post-anesthetic nausea and vomiting. So generally we give ondansetron to the patients. Ondem dewa hoy post-operative period e, okay, which is a 5-HT3 blocker. Proton pump inhibitors or H2 blockers. What will happen? Proton pump ki korbe? Inhibitors gastric pH টাকে কি করবে? I told you already. pH টাকে increase. Gastric pH to around 1.3 or 1.8 এরকম থাকে এই রেঞ্জে, এটাকে বাড়িয়ে দেবে। It will take it to more than 3.5. Okay, and the volume of the gastric juice is also reduced. So this is the main effect. ঠিক আছে, যত কম ভলিউম গ্যাস্ট্রিক জুসে থাকবে রিফ্লাক্সের চান্স কি হবে? কমে যাবে। ভলিউম বেশি থাকবে বেশি রিফ্লাক্স হবে। Okay. What are the drugs that also prevents the stress ulcers? What are the drugs that we give? Ranitidine, famotidine, omeprazole. We generally give night before the operation and early morning. Okay. Next, again a short note, balanced anesthesia. You can also get a long question, several questions combined into one. Balanced anesthesia. What do you mean by balanced anesthesia? Balance. Mane? If you give one drug at a very high dose, that is better, or different group of drugs in a balance, so that we get all the effects without much side effects. Okay? Balanced anesthesia. We get quick actions, longer period of time, with a low dose with a smooth induction. That is balanced anesthesia. Balanced anesthesia de ki kora hoy? Balanced anesthesia, once you are combining IV anesthetics and inhalational anesthetics. আগের দিন কি পড়ানো হয়েছে? Inhalational পড়া হয়েছে তো? Gaseous anesthetics পড়ানো হয়েছে তো আগের দিন? Inhalation gaseous anesthetics পড়ানো হয়েছে তো আগের দিন? You don't remember also. কি পড়ানো হয়েছে? হ্যাঁ? So modern anesthesia, this is a modern anesthesia. How come? We are combining the intravenous with the inhaled drugs. We are combining them. When you are giving the intravenous shot, direct IV যাচ্ছে, very short span of time, it will induce the anesthesia. তারপরে কি করো? Inhaled drugs দিয়ে maintain the anesthesia. And you give muscle relaxants. What else? You give analgesics. What else can you give? And you can also give the cardiovascular drugs. What is the definition of balanced anesthesia? When you are giving drugs from different groups to get a smooth anesthesia in a short period of time for a longer duration. Understood? Clear? Balanced anesthesia is giving drugs from different groups. IV anesthetics দেওয়া হচ্ছে, inhaled anesthetics দেওয়া হচ্ছে, muscle relaxants দেওয়া হচ্ছে, analgesics or opioids দেওয়া হচ্ছে, and what else? And cardiovascular drugs, যাতে autoimmune responses or reflexes is subdued. Okay, understood? So this is the definition of balanced anesthesia. Generally we give IV anesthetics for induction. এটা seconds এ কাজ করে. In 10 to 15 seconds the patient gets sedated, and then we maintain the anesthesia with the inhaled anesthetic. Okay, so that is balanced anesthesia. Short note আসতে পারে, balanced anesthesia, important groups of drugs that are given, important. What are the drugs that are given for induction? Important. What are the drugs that are given for maintenance? Important. Okay. ক্লাসিফিকেশন করেছিলে আগের দিন? ইনহেলেশনাল ড্রাগস পড়া হয়ে গেছে, গ্যাসেস, ভোলাটাইল লিকুইডস পড়া হয়ে গেছে। নাও উই উইল বি স্টাডিং টুডে ইন্ট্রাভেনাস। ইন্ট্রাভেনাস মানে আইভি তে দেওয়া হচ্ছে। What are the drugs? These are again divided into different groups, either fast acting or it is slow acting. Fast acting এর মধ্যে কি আসছে? What do we get in fast acting? Thiopentane sodium, methoxytone, propofol and etomidate. Next, slower acting এর মধ্যে benzodiazepine. Then we have the dissociative anesthesia, again an important short note, ketamine and opioid analgesic fentanyl. Okay, we start with thiopentane sodium. That is an intravenous anesthesia, IV তে দেওয়া হচ্ছে. It is very alkaline. Okay, it is ultra short acting thiobarbiturate. Thiobarbiturate group এ belong করে, very ultra short acting. কেন? Because it acts in seconds. যেই দেওয়া হচ্ছে in seconds. Okay, it has to be prepared freshly before the injection. And if by chance this goes into the artery, what will happen? Extravasation যদি হয়ে যায় বা তুমি ভুল করে আর্টারিতে যদি দিয়ে দাও instead of the vein, then what will happen? There will be pain, necrosis and gangrene can occur. So you have to be very careful. This is an MCQ also, important MCQ. Which drug, if given inadvertently to the artery, can cause gangrene, necrosis, and pain, severe pain. So that is thiopental sodium. When it is injected IV, it produces unconsciousness in 15 to 20 seconds. I told you ultra short acting কেন বলা হচ্ছে? Only 15 to 20 seconds এর মধ্যে anesthesia you can induce the patient. It is highly lipid soluble, so it can enter the brain very fast. Consciousness is regained in 6 to 10 minutes. 6 to 10 minutes এ patient conscious হয়ে যেতে পারে। So induction এর জন্য ইউজ করে, মেইনটেনেন্স কি ইউজ করা যাবে কিনা? Anesthesia. Okay, sit down. So the consciousness is regained in 6 to 10 minutes. In 15 to 20 seconds, the patient becomes unconscious. But in 6 to 10 minutes, again the recovery occurs. Okay, so it is used for mainly the induction purpose. কেউ বুঝতে পারছে induction মানে কি আর maintenance মানে কি? Induction মানে কি? Any one of you? Induction মানে start the general anesthesia, patient কে unconscious করছো. When you are starting it, that is the induction. আর তারপরে maintain that unconscious state, that is maintenance. So this drug is for induction না maintenance? Induction, ultra short acting induction করছি আমরা. Okay. Now on repeated injection, what happens? The extracerebral sites are gradually filled up. Okay, and lower doses can produce the anesthesia for longer period of time. Repeatedly যখন দিচ্ছ তখন extracerebral sites যেটা আছে সেখানে তো drugs distributed আছে. Okay, and what will happen? So next you are requiring lower amount of drug. যেটা ইনডিউস করার সময় যে ভলিউমটা দিয়েছিলে মেইনটেইন করার জন্য সেই ভলিউমটা দেবে না। ক্লিয়ার? Because of the distribution of the drug. Hepatic metabolism হচ্ছে CNS depression can persist for more than 12 hours. So if you are giving thiopental sodium to the patient, 12 ঘন্টার আগে হসপিটাল থেকে ডিসচার্জ করবে না, কারণ CNS depressed থাকবে for around 12 hours. Okay, তাহলে patient will be staying in the hospital, will be not be discharged before 12 hours, কারণ CNS depressed থাকে। It is poor analgesic. I already told you কিছু কিছু drugs আছে যারা poor analgesic. So what do you give? Analgesia strong করার জন্য কি দেওয়া হয়? Opioids. I told you all. So this is a poor analgesic. Patient will struggle, shout, and show reflex changes in the BP and respiration. Painful procedures with opioid or nitrous oxide. Understood why opioid or nitrous oxide has to be given? Because it is a poor analgesic. It is a weak muscle relaxant. So you have to add a muscle relaxant. Muscle relaxant কি দেওয়া হয়? Generally succinylcholine. Yes? পড়া হয়েছে? Local anesthetics, muscle relaxant এগুলো পড়া হয়ে গেছে তো? Okay. Respiratory depression is marked. BP falls immediately. Cardiovascular collapse can occur because of the hypovolemia. So these are the disadvantages. কি কি হচ্ছে? একটা হচ্ছে CNS depressed, cardiovascular system এ কি করছে? BP hypotension করে দিচ্ছে, hypovolemia করে দিচ্ছে, cardiovascular collapse করে দিতে পারে। Okay, reflex tachycardia, but it does not sensitize the heart to adrenaline. তাই জন্য কি হবে না? Arrhythmias doesn't occur. Arrhythmia will not occur because it doesn't sensitize the heart to adrenaline. So these are the disadvantages. কি বললাম? Weak analgesic, next weak muscle relaxant, cardiovascular system কে ডিপ্রেস করে দিচ্ছে, রিফ্লেক্স ট্যাকিকার্ডিয়া করছে, রেসপিরেটরি সিস্টেম কে ডিপ্রেস করছে, অ্যাপনিয়া হওয়ার চান্স থাকছে। The cerebral blood flow is also reduced. Cerebral oxygenation does not suffer. Greater decrease in cerebral oxygen consumption and cerebral perfusion is maintained. Commonly, it is used as only as an inducing agent. I told you. তাহলে কি অ্যাডভান্টেজ কি আছে? ডিসঅ্যাডভান্টেজেস পড়ে নিলাম, অ্যাডভান্টেজ কি আছে? ফাস্ট অ্যাক্টিং, ফাস্ট ইন্ডাকশন করছে, আর অ্যারিথমিয়া করে না, আর ইট ইজ নট ভোলাটাইল, তাহলে এক্সপ্লোশন হওয়ার চান্স নেই, যেটা আমাদের ইনহেলেশনাল অ্যানেস্থেটিক্স এর একটা ভয় থাকে সবসময়, এক্সপ্লোশন। তো নো চান্স অফ এক্সপ্লোশন। It can cause laryngospasm, respiratory secretion or irritants present, or intubation attempted. Anesthesia is light. It is prevented by atropine. Pre-anesthetic medication দিতে হচ্ছে, নালে একটু যদি সিক্রিশন আসবে তাহলে কি হবে? laryngospasm. মাসল রিল্যাক্সেন্টের জন্য কি দেওয়া হচ্ছে? সাকসিনিল কোলিন সেম সিরিঞ্জে ইউজ করা যাবে না, রিঅ্যাকশন হয়। You don't use succinylcholine and thiopentane, they react chemically, so should not be given in the same syringe. Poor muscle relaxant, I already told you all, thiopentane is a poor muscle relaxant, poor analgesic. তাহলে opioids ও দিতে হবে, muscle relaxants ও দিতে হবে, but don't use the same syringe, because thiopentane sodium and succinylcholine, they will react chemically and it will produce adverse effects. So you should not be mixed in the same syringe. Shivering and delirium hoy, recovery period যখন হয়, patient will shiver, so you should note that it is because of the thiopentane sodium. Pain in the post-operative period, because it is poor analgesic, analgesia, poor opioids you are giving, so the patient will feel restless in the post-operative period. It can precipitate acute intermittent porphyria in the case of the susceptible patient. Other uses are কি কি থাকতে পারে? It can be used in the control of convulsions, আর নার্কো অ্যানালিসিস যখন করা হয় পেশেন্টদের তখন তো ইউজ করা যেতে পারে। ওকে, so this is the two other uses other than the induction. Propofol, this is also very short acting. It is milky white, it is oily in nature. It is an oily liquid and it is present as 1% emulsion. Unconsciousness কতক্ষণে পাওয়া যাচ্ছে? In 15 to 45 seconds. তাহলে এটাকেও ইউজ করতে পারি as induction. It rapidly distributes. Distribution period কি আছে? টিহা 2 to 4 minutes. আর elimination in 100 minutes. It is much shorter than that of thiopentane sodium. 100 minutes আর ওর কত ছিল? 6 to 10 minutes. এটা কত ছিল ওটা? 6 to 10? No, that was not elimination. That was distribution. Patient recover করছিল কিন্তু consciousness CNS depressed for more than 12 hours থাকছিল আর এখানে eliminated করে না 100 minutes only. Okay, so intermittent injection or continuous infusion of propofol, একটা প্রোপোফল দিয়েও আমরা পুরো ওটি করে নিতে পারবো। কন্টিনিউয়াস ইনফিউশন করতে হবে, বারে বারে দিতে হবে, আর ইন্টারমিটেন্টলি দিতে হবে। ওকে, তাহলে একটা শর্ট প্রসিডিওর অনলি প্রোপোফল দিয়েও করা যেতে পারে। It lacks the airway irritancy and induces the bronchospasm. It is suited for outpatient surgery. খুব ছোট প্রসিডিওর থাকলে অনলি প্রোপোফল দিয়েও করা যেতে পারে। ওকে, in what outdoor procedures, incidence of post-operative nausea vomiting is low, and fall in the BP, baroreflex, এগুলো same as that of the thiopentane sodium. Respiratory depression ও থাকবে। Cerebral blood flow same as that of thiopentane sodium. Pain during injection is frequent, so you mix it with the local anesthetic. কি local anesthetic দেওয়া হয়? lidocaine. Okay, next, তাহলে অ্যাডভান্টেজেস বলো প্রোপোফলে। শর্ট অ্যাক্টিং ক্যান বি ইউজড ফর ইন্ডাকশন, ডে কেয়ার সার্জারি, রিপিটেডলি দেওয়া যেতে পারে, আর ভোলাটাইল নেই, এক্সপ্লোশন হবে না, আর অ্যাড্রিনালিন will not cause arrhythmia. It will not sensitize the heart to adrenaline. ডিসঅ্যাডভান্টেজ বলো। রেসপিরেটরি ডিপ্রেশন করছে, কার্ডিওভাস্কুলার সিস্টেম ডিপ্রেস করছে, আর হ্যাঁ painful আছে, so has to be mixed with local anesthetics, that is lidocaine. So this is the disadvantage. Next is etomidate. Induction of anesthesia, this is also short acting, তাই জন্য induction করা যাবে না এর থেকে। The main advantage is it has minimal cardiovascular and respiratory depression. এতক্ষণ কি বলছিলাম, cardiovascular system depress করছে, respiratory system depress করছে। যদি কোনো হার্টের পেশেন্ট থাকে who has already compromised status of the cardiac activity, তাকে কি আমরা কোনোদিন জেনারেল অ্যানেস্থেসিয়া দেবো না? দেবো। তখন কি কোনটা দেবো? ইটোমিডেট। যার লো কার্ডিয়াক রিজার্ভ থাকবে তাকে আমরা we will prefer etomidate for induction of the anesthesia. Clear? Heart rate remains unchanged. ওখানে কি হচ্ছিল? রিফ্লেক্স ট্যাকিকার্ডিয়া হচ্ছিল, এখানে unchanged. Incidence of apnea is also low, তার মানে respiratory depression কম, তাই chances of apnea is also low. No analgesic effect, it has no analgesic and it has to be co-administered with the opioids. Analgesia করে না, so you have to give opioids. Recovery is less rapid, less than 10 minutes compared with the recovery from the propofol. So it is less rapid. Distribution of etomidate is rapid with a biphasic plasma concentration. Biphasic half life দেখো, একটা হচ্ছে 3 minutes আর একটা হচ্ছে 29, so you have two plateaus. Okay, redistribution is short duration of its anesthesia. Because of the redistribution of the drug, it has short duration of action. Okay, it is extensively metabolized in the liver, high incidence of pain on the injection, myoclonic activity and post-operative nausea vomiting is there. It causes, main disadvantages, it causes adrenocortical suppression. What will happen? Adrenocortical suppression will, it will prolong the infusion in critically ill patients, hypotension করাবে, electrolyte imbalance করাবে, oliguria হবে because of the adrenal suppressive effects. Okay, so this is the main disadvantage. Advantage কি ছিল? Respiratory আর cardiovascular সিস্টেমের উপরে ডিপ্রেসিং এফেক্ট থাকছে না, লো কার্ডিয়াক রিজার্ভ যে পেশেন্ট গুলোর আছে সেখানে ইউজ করতে পারছি, শর্ট ডিউরেশন অফ অ্যাকশন আছে, একটা ডিসঅ্যাডভান্টেজ আছে that is adrenocortical suppression, আরেকটা ডিসঅ্যাডভান্টেজ আছে কি, আরেকটা আছে it has no analgesic effect, so you have to give it with the opioids. Okay, clear? Bolo, it undergoes redistribution, it is short duration of its anesthetic effect but in the peripheral extracerebral part ছেড়ে অন্য জায়গায় থাকছে, so it is staying in the body, that will prolong the action of duration but consciousness কোথা থেকে হবে? Brain. তাহলে shorter duration, we are main concerned with the consciousness. GA মানে কি? Consciousness, loss of consciousness. তাহলে আমাদের ওটা শর্ট হয়ে যাচ্ছে, but it will remain in the body. Distribution হচ্ছে বডিতে থাকছে, এক্সট্রা সেরিব্রালি বাইফেজিক আমরা পাচ্ছি, দুটো কার্ভ পাবো, একবার ব্রেনে চলে যাচ্ছে, বডি থেকে মেন ব্রেনে চলে গেল, তখন একটা হাই ডোজ পেলাম, তারপরে যখন বডিতে পুরো ডিস্ট্রিবিউট হলো তখন আরেকটা ডোজ পেলাম কার্ভ। ওকে, ক্লিয়ার না? Benzodiazepines. Benzodiazepine, we have used it as a pre-anesthetic medication. It is used for inducing. It can also be used for maintaining and for supplementing the anesthetic. Okay? তাহলে benzodiazepine এর তিনটে কাজ, একটা হচ্ছে ইন্ডাকশন, একটা হচ্ছে মেইনটেনেন্স and also the supplements the other anesthetics. Okay? It produces sedation, amnesia and unconsciousness in only 5 to 10 minutes. কিন্তু ওইগুলো ছিল in seconds and this is in minutes. Okay? So those are called ultra short acting. So এটা benzodiazepine is not ultra short acting. ওইগুলো seconds এ হয়ে যাচ্ছে. When you push in 15 to 20 seconds the patient is unconscious. এখানে 5 to 10 minutes লাগছে patient. If no other anesthetic or opioid is given, the responsive in 1 hour or so due to redistribution of the drug. Okay? 1 ঘন্টা লাগবে থাকতে পারে ওর এফেক্টটা because of the effect of redistribution. Distribution T-half is 15 minutes. Amnesia persists for 2 to 3 hours. Amnesia মানে মনে থাকবে না কিছু. And sedation for 6 hours. পেশেন্ট সবসময় স্লিপি ভাব থাকবে till 6 hours. Okay. Poor analgesic, opioid has to be given or nitrous oxide has to be given in case of the painful procedure. It will markedly depress the respiration. তাহলে respiration apnea হবার চান্স থাকবে, cardiac contractility or BP. Decrease the muscle tone by central action. And it is preferred in case of short procedures. দেখো এন্ডোস্কোপি যখন করতে যাওয়া যায় তখন বেনজোডাইজিপিন, কার্ডিয়াক ক্যাথেটারাইজেশন যখন করা হয় তখন, in case of fracture settings, in conscious sedation during local or regional anesthesia, not long procedures. বেনজোডাইজিপিন short procedures এর জন্য দেওয়া হয়। ওকে, কি ফ্র্যাকচার যখন সেটিং করা হয় তখন, প্লাস্টার করা হচ্ছে, অনেক পেইনফুল প্রসিজার, ইউ জাস্ট সিডেটেড, পেশেন্ট অ্যানালজেসিক হয়ে গেল, পেশেন্ট অতটা ব্যথা বুঝতে পারছে না, অ্যামনেসিয়া থাকলো। ওকে, আর এন্ডোস্কোপি যখন করা হয়, ওকে, কোলোনোস্কোপি যখন করা হয়, আর কার্ডিয়াক ক্যাথেটারাইজেশন যখন করা হয়, অ্যানজিওগ্রাফি করা হলে, বা ইন কেস অফ কনশিয়াস সিডেশন ডিউরিং লোকাল অর রিজনাল অ্যানেস্থেসিয়া। It is also a frequent component of balanced anesthesia. Balanced anesthesia, I told you what? Balanced anesthesia te benzodiazepine add kora hoy. Next is ketamine. Dissociative anesthesia, important short note. Again, what do you mean by dissociative anesthesia? Dissociative anesthesia পুরোটা আনকনশিয়াস হবে না, পেশেন্ট লাইট স্লিপে থাকবে, বুঝতে পারবে কিছু হচ্ছে, but he will be feeling away from his brain and body. Okay. কি what প্রফেসর থাকবে, ওটা বুঝতে পারবে যে something is going on, but he will be unable to process the stimuli and move his body parts. Okay, most important, he will understand something is going on, but ওই স্টিমুলিটাকে সেন্সরি he will not be able to move it into a motor action and move his body. So he will be feeling away from his brain and away from his mind. So patient appears to be conscious. He can open his eyes. মনে হবে যেন conscious patient. He will have the swallowing movements থাকবে. Swallowing movements, and his muscles are stiff. Site of action কোথায় আছে? Cortex and subcortical areas. What are the receptors that are involved? NMDA receptors are involved. Is intracranial pressure. Why? Because ketamine is a drug which is increasing all the pressures. সেটা কার্ডিওভাস্কুলার সিস্টেম হোক, ইন্ট্রাক্রেনিয়াল হোক, ইন্ট্রাঅকুলার হোক, যে প্রেসারই আছে বডিতে, ketamine is a general anesthetic which will increase all the pressures. So it is dangerous for hypertensive, ischemic, congestive heart failure, and those with raised intracranial surgery. Okay, এটা একটা ketamine disadvantage. It is increasing all the pressures. Maybe it intracranial, intraocular, or hypertension, BP, blood pressure. Next, fentanyl. Fentanyl কোন গ্রুপের ড্রাগ? Opioids. Most commonly used opioid for balanced anesthesia. Fentanyl, most common analgesic in opioids. Fentanyl. It is highly lipophilic, short-acting, potent opioid analgesic. Reflex effects of the painful stimuli are abolished. Mainly as an analgesic, we are using it. It is used to supplement in the case of balanced anesthesia. Balanced anesthesia te two important parts. একটা বললাম benzodiazepine, আর একটা কি বললাম? Opioid. Benzodiazepine কি করে? Anxiety. Opioid কি করে? Analgesia. Amnesia, benzodiazepine. Okay. Analgesia this. Lower anesthetic concentration with better hemodynamic stability. When you are using fentanyl, anesthesia effect টা কি হয়ে যাবে? ডোজটা কি হয়ে যাবে? Lower doses are required. তাহলে ডোজটা রিডিউস হয়ে যাবে। ওকে, combined with benzodiazepines, I already told you, diagnostic procedure, endoscopy, angiography in poor risk patients, burn dressing করতে পারা যাবে। Anesthetic awareness with dreadful recall is a risk. নাইট রেস হয় না, ওইরকম ওপিওয়েড দিলে কখনো কখনো ড্রেডফুল রিকলস হবে পেশেন্টের। ওকে, আফটার আইভি ফেন্টানিল patient remains drowsy, but the consciousness and his cooperation can be commanded. Drowsy থাকবে patient, but you can command. Okay? So this is an advantage. But you have disadvantages also. There is marked respiratory depression. Tone of the muscles, chest muscles and the masseters increases. खूब stiff हो जाए. So you have to give a muscle relaxant. Heart rate decreases because it stimulates the vagus. Vagus nerve কি করে? Bradycardia. Fall in the BP is slight. Cerebral blood flow and oxygen consumption slightly decreased. Fentanyl, it is given as an adjunct to spinal and nerve block anesthesia and to relieve the post-operative pain. তাহলে what are the advantages and what are the disadvantages? বলো। Advantage of fentanyl, amnesia, good amnesia, একদম ব্যথা থাকে না। আর balanced anesthesia, general anesthesia তে lowering the dose of general anesthesia. আর disadvantage করে না। আর বারবার দেওয়া যেতে পারে, বার্ন ড্রেসিং পেশেন্টকে দেওয়া যেতে পারছে, সো ইট ইজ সেফ। আর ডিসঅ্যাডভান্টেজ, হার্ট রেট কি করছে, কমে যাচ্ছে, রেসপিরেশন ডিপ্রেশন করছে, সো দিস আর দ্য ডিসঅ্যাডভান্টেজেস। আরেকটা হচ্ছে কি, চেস্ট মাসল এন্ড ম্যাসেটার্স কে খুব টট করে দেয়, খুব টাইট হয়ে যায়, তো মাসল রিল্যাক্সেন্ট দিতে হবে। ওকে, দিস আর দ্য ডিসঅ্যাডভান্টেজেস। সো দিস ইজ অল in short, পুরোটা in one slide. Intravenous কি কি পড়লাম, short recapitulation of the class, কি কি পড়লাম, হ্যাঁ 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 wouldn't just বলা, wouldn't আর ম্যাসেজও ইয়ে হয়ে যায়, short হয়ে যায়, so it is making the muscles stiff. Anyone? কেউ উঠবে? anyone can you volunteer? আমরা কি কি পড়লাম আজকে? So first thing, pre-anesthetic medications কাকে বলে? Those medications that we give before giving anesthesia, they are called pre-anesthetic medications. Pre-anesthetic medications দিয়ে আমরা কি করব? anxiety patient এর হয় প্রি অপারেটিভ পিরিয়ডে, সেটাকে কমাবো। আমরা প্রোটন পাম্প ইনহিবিটরস দিয়ে কি করব? আমাদের গ্যাস্ট্রিক সিক্রিশনের ভলিউমটাকে কমাবো আর পিএইচটাকে বাড়িয়ে দেবো। তাতে যদি পেশেন্ট রিফ্লাক্সও হলো, অ্যাসপিরেশন হলে খুব বেশি লাং ড্যামেজ, কেমিক্যাল নিউরাইটিস হওয়ার চান্স কমে যাবে। ওকে, হোয়াট আর ইউ ডুইং? উই আর ডিক্রিজিং দ্য সিক্রিশন। আমরা সিক্রিশনই কমিয়ে দিচ্ছি। আমাদের কি সিক্রিশনস উই আর ওয়ারিড অ্যাবাউট? স্যালাইভারি, মুখে থাকছে, আর ব্রঙ্কিয়াল সিক্রিশন, যেটা লাংসে যেতে পারে, অ্যাসপিরেট করতে পারে পেশেন্ট। সো উই আর ডিক্রিজিং দ্য সিক্রিশন। অ্যানালজেসিয়া, কি দিয়ে অ্যানালজেসিয়া দেবো? ওপিওইডস আর একটা মাসল রিল্যাক্সেন্ট দিচ্ছি, দ্যাট ইজ সাকসিনিলকোলিন ইজ প্রেফার্ড। So these are all the drugs, different group of, otherwise we are giving beta blockers or alpha agonists, because adrenergic system তখন stimulate হচ্ছে, তার রেসপন্স গুলোকে ডিক্রিজ, সাপ্রেসড রাখার জন্য। So these are all the drugs that are given in the pre-anesthetic medication. Next, what are we doing? What do you mean by balanced anesthesia? Balanced means different groups of drugs when they are combined together and given to have a smooth induction and maintenance of the anesthesia without much adverse effects of these drugs, and we are also decreasing the dose of a single drug. So different groups of drugs when combined together and given in anesthesia, that is a balanced anesthesia, that is the modern form of anesthesia. Generally we prefer the IV anesthetics for, because they are very ultra short acting for induction, and inhalational for the maintenance of the anesthesia. We have already studied the inhalational. Today we have studied intravenous anesthesia. Intravenous anesthesia এর মধ্যে short acting, long acting. Short acting এর মধ্যে আমরা কি করলাম? Thiopentane sodium, etomidate, propofol. Dissociative anesthesia is another anesthesia. Which one is the dissociative anesthesia? Ketamine. Other opioid anesthesia কোনটা বললাম? Fentanyl. So this is all of the anesthesia. This ends the anesthesia. Okay? Thank you.